Well, some other things I already mentioned, the central nervous system. I think that is something that we really have to be aware of and keep that in mind. Difficult word, cytokines, and I will come back to it later. There are, let's call them proteins that are circulating in our blood, and they can cause growth and function. They are very important. We all have them. But for example, when you have a fever, some of the cytokines can be elevated, and we know that lots of the signs and symptoms for HLH as well as for LCH are due to an overproduction of cytokines. And so we do know what is causing the signs and symptoms. We do not always know what is sort of the initial, let's call it stream upwards, what is causing the cytokine storm. Although in HLA nowadays we do know that there are certain genetic defects, or there are gene defects in this disease. And of interest is that in the different countries, and I'm sure that Dr. Filipovic will talk about it, in different countries you have different defects. For example, in the Netherlands we have a lot of people who come from Turkey, and sometimes those are people who come from a smaller city, and they are sort of interrelated. So of course when there's an abnormality in one family, and you marry with your cousin or your niece, then obviously there's a chance that she has this abnormality as well. When you have, and it's genetic abnormalities, and when you have one problem and one is good, then the good one will take over, and you don't see the problem. But when there is a family with one problem and one good one, and they marry, and they both have one problem and one good one, 25% will get the problem and the problem gene for the mother and the father, and then you have HLH. So we see in those certain groups of patients, we see more problems, for example, in the Turkish families. Well, the treatments, few words. In the past, virtually 100% died of HLH, and I think, they tried a lot of things, but now within the Histiocyte Society, we moved on and came to, we now have a patient, we register, and if it is a familial case, we go through the protocol. If it's resolved, if it's a secondary and it's resolved, you can stop treatment. So we know now what to do, and again, these are guidelines, not only for us, but every physician in the world can use these kind of guidelines and know now how to treat these diseases. 1994 was the first international protocol. We are now in 2004. We had the second. And actually, just to show you, in 1994, we started cyclosporin on week 8-9. And here there was no cyclosporin. When we look back to our database, we saw that a lot of patients passed away in the first 8 weeks. So just a small change in the 2004 that we added cyclosporin, and we hope we just cure those patients who didn't do well in the first 8 weeks. The overall survival, however, has been, I think, tremendous. 55% of whole HLH 94 survives of this disease, and again, as I showed you earlier in the beginning, virtually 100% of the patients died of this disease. Furthermore, you have to realize this is not only USA or Western Europe. There are also countries involved where the standards, although the physicians are quite good, the standards of care are not less developed. I know I went to Argentina, and the physician told me, we do very well, but the moment that they leave the hospital, they go back to their villages, and they don't take care about cleanliness, about food, or those kind of things. When I went to Brazil, they said, if they give them money to come back to the hospital, they use the money for other things. So nowadays they give them bus tickets, because with the bus tickets they have to come to the hospital. So those are really problems, and in an international protocol, this has to be taken into consideration as well. My last 5 slides, my story of my research life, I guess. I think that LCH is one big puzzle. And what we did over the years, what I try to do is, I would like to finalize the puzzle before Jeff is, leaving the association, I guess. So, and every time what I do is I pick a little piece of the puzzle, and I try to find somebody who knows a lot about this problem, who doesn't know about LCH. But for example, when I talk about, let's call cytokines, there was a person somewhere in the Netherlands who is doing a lot on cytokines, had never heard of LCH, and I came in contact and I tried to work together, and we found that cytokines is very important in this disease. Chemokines the same, and I'm just going to show you 4 slides because I think it's intriguing. This is a slide to show you that the normal Langerhans cell, it's called an antigen presenting cell. It's a cell with lots of arms. It picks up, let's call it a virus, or we call it antigen. It will pick it up. So that's why it's in the skin. They have kind of arms. They pick up antigen, and then they roll to the lymph nodes where certain cells can kill those antigens, those viruses. So the Langerhans cell is kind of a person who is at the gate and said, you're good, you're not good. The one who's not good, he picks up and he rolls with it to, let's call it the cellar, and there are the killers, and they chaka, and then they're dead. So Langerhans cells are very important in our immune system. They are really the first cells that are there. But in LCH, the Langerhans cells are more rounded. They lack these arms, so they are in a different state. So we know now that there is something different. And one of the things that we try to find out is, why are they different? Can we find out? Because if we know that they are different, we know, is there a state of the cell that it stops to become more, that it goes to the lymph node? And what we did is, normally, and I'm just going to call you the 6 and 7, it makes it a little bit easier. Don't look at CCR, it's difficult names. When you're in the skin, you're 6 positive and 7 negative. To go to the lymph node with your virus, you have to downregulate 6 and upregulate 7. So you have to be 6 negative and 7 positive to roll to the lymph node. So the cells that are made in the bone marrow, they go to the blood, go to the skin, where we saw the Langerhans cells with the arms. They are 6 positive, 7 negative. They are quite immature. They pick up the virus, and then they become more mature, and they downregulate the 6, and they become upregulated for the 7, and they go to the lymph node, and there are the killers. Chaka. However, in LCH, what is happening? We checked in 22 samples. All the cells in LCH are 6 positive and 7 negative. So they stop. They cannot become more mature. They cannot roll to the lymph node. So they are stuck in their environment. And, of course, we thought if we can give a treatment and kick them a little bit and they become a little bit more 6 negative and 7 positive, maybe they can go to the lymph node. Well, it's not happening. We see that the LCH cell can be compared with other dendritic cells, but there is a maturation block. They stop. You cannot get them out of, and that's why they are stuck in their lesion. They are 6 and they're not 7, and that's why they are stuck in this lesion. And this is just something that we need to know, because treatment for a 7 might be different for a 6. When you want to kill a cell, it's so complicated, but it's also fascinating. So this is one of the little pieces of the puzzle. I just hope to finalize the puzzle before Jeff and I will be retiring. Thank you very much for your attention.